Okay, so we're just going to go ahead and get started. Thank you everybody for joining us today. We're going to be presenting on visualizing mental health and SDOH in public housing, brought to you by the National Center for Health in Public Housing. So before we get started, these are just a few housekeeping items to keep in mind. All participants are muted upon entry. Please make sure that if you have any questions or any promising practices that you would like to share related to this topic, that you can do so by engaging in the chat. Raise your hand if you would like to unmute as well. And the meeting is also being recorded. The slides and the recording link will be sent via email after today's session. And also, my name is Fide Pineda, and I am the Training and Technical Assistance Manager for the National Center for Health in Public Housing. And Kevin, would you like to introduce yourself?
Hi, I'm Kevin Lombardi. I'm a physician epidemiologist, and I'll be your primary instructor today.
Thank you so much. So this is just some information about NCHPH. The mission of the National Center for Health in Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration, and is also a national training and technical assistance partner, and is 100% financed by this grant. The information presented today are those of the author. So this is just some background information about health centers that are close to public housing. According to the 2021 health center data by HRSA, there are over 1,000 federally qualified health centers that serve to 30 million patients, 458 FQHCs that are immediately accessible to public housing that serve to 5.7 million patients. And of those, there are 108 public housing primary care grantees that serve to 911,683 patients. So this is just some public housing demographics information according to HUD data. In public housing, there are 1.5 million residents, two persons per household, 38% are disabled, 52% are white, 43% are African American, 26% are Latinx, 19% are elderly, 36% are children, and also 91% are of low income, with 32% that are female-headed households with children. Now we'll pass it on to Dr. Kevin Lombardi.
Hi, everyone. So this is going to be a fun session. It's going to be participatory, and we're going to get the opportunity to look at our interactive maps and for you to kind of take a look at what your surface area is and some of the unique dynamics that you see manifest. So the session background, sorry, itchy fingers here. So the burden of behavioral health conditions on individuals in traditionally marginalized communities is significant. These conditions impact health center patients in a variety of ways that are cumulative, insidious, and often difficult to address. In this webinar, we seek to gain a greater understanding of the behavioral health burden on community health centers through data visualization. Specifically, using the interactive maps, we examine the main metrics related to behavioral health, the SDOH, and their interaction. Using this understanding, I hope to bridge the conversation to discussing the latest research and program creation efforts to use to better address the behavioral health burden in your community. Next. So to break this down into the four main areas that we'll be focusing on today, one is to visualize and describe the impact of behavioral health conditions and the social determinants of health on community health centers. Two, to gain better understanding of how these issues interact. Three, to review recent research in addressing behavioral health systemically from the health center level. And four, examine ways to integrate best practices and available research into actionable program design. Next, please. So section one is visualization. I'll be going over a little bit of background first, and then we'll be going straight to the maps and doing some exercises together. Wait a minute, let me just make sure I get my notes and I'm keeping up with you today. 1 second. Okay, next slide, please. Excuse me, I need to get rid of my assistant. The social determinants of health are factors in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. Many individuals that receive public housing assistance in neighborhoods with low access to high quality healthcare and social service, or in areas that are unsafe. These environments play a large role in determining the physical and behavioral health status of public health residents. And this is a really kind of cute and helpful diagram in the middle that helps break these things down. And the social determinants of health are very complex. So this is a bit of a modular approach, but helpful nonetheless. Breaking it down into education, access, and quality, economic stability, social and community context, neighborhood and built environment, and healthcare access and quality. So education has a well-established connection to health, with years of formal education correlated with a healthier and longer life expectancy. The impact of low levels of education is not limited to childhood, adolescent, or one's working years, but this continues past into their elderly years as well. The money we make, the connections we make, and the social environment that we build ourselves is a lot of it's predicated on the education, access, and quality we receive throughout our lives. Economic stability. Individuals with employment are more likely to experience positive health outcomes and experience lower rates of heart disease, diabetes, and other chronic conditions. Social and emotional context, social and community context, excuse me. People's relationship with family, friends, coworkers, and community members impacts their physical and psychological health and well-being in a very real and intimate way. Unsafe housing, discrimination, or economic impoverishment acts as barriers to these. Neighborhood and built environment. Access to housing is a critical component of healthy living. Unhoused populations are largely limited to ED care and lack access to preventable services. Quality and location of housing is linked to preventative health service access and the necessary components of healthy living, such as healthy diet and pollution-free living. And finally, healthcare access and quality. 1 in 10 Americans do not have access to healthcare, period. Many more are medically underserved and lack access, particularly to preventative services. And next, please. So here in this diagram, we review some of the prevalence of selected health conditions in HUD-assisted adults and low-income renters and all adults to sort of contextualize the disproportionate health burden on HUD-assisted and low-income renters compared to all adults. And we have 3 columns here: HUD-assisted, low-income renters, and all adults. And in general, individuals that receive housing or rental assistance from the U.S. Department of Housing and Urban Development are more likely to have chronic health conditions and are higher utilizers of healthcare than the rest of the U.S. population, including other low-income renters. They're more likely to be fair or poor health, overweight or obese, or have a disability or diabetes. And some of these metrics are actually pretty significant. If you compare fair and poor health from HUD-assisted adults to all adults, it goes from 13.8% to 35.8%. That 17 or so percent represents hundreds and hundreds of thousands of people. We can see also a pretty significant difference in disability for HUD-assisted versus all adults. They're almost twice as likely to have a disability than all adults in the general population. And some of the other conditions that are reviewed here, diabetes, COPD, these are conditions that have significant morbidity and mortality associated with them, and risks that affect people's lives in a myriad of ways. So the disparity is significant. Next, please. Individuals that receive housing or rental assistance from HUD are also disproportionately more likely to suffer from poor mental health. They have a higher probability of reporting feelings of anxiety, depression, and hopelessness, and those feelings are predicted to interfere with daily activities more often and more seriously than the general population. And this isn't a relationship that should be surprising to us. If we can imagine how any of us would react if our housing was less stable than it is now, that would likely affect our mental health in a variety of ways. The anxiety we have going through our day-to-day activities would be very different if we didn't have stable housing. But the interesting thing here is just the size of the disparity. If you look at public housing residents distressed with mental hardship is about 39%. And with the general adult population, it's 21.40%. That's a large disparity, and it's important to notice how it's important to take away here the primary position of housing within that disparity because of the two populations that we're looking at. And the important thing here is that mental health and physical health are mental health, physical health, and the built environment are intricately connected. Depression and anxiety can impact individuals' ability to engage in healthy behaviors, while physical health conditions can create additional obstacles to accessing mental health care. And when we look at this disparity between the general adult population and public housing residents, some of the other disparities that we see make a little more sense. For example, the disparity with diabetes, the disparity with COPD. People who are experiencing higher rates of anxiety and higher rates of depression are more likely to engage in the behaviors that make it more likely that you have those conditions. Behaviors such as eating unhealthy foods. And if we look at consider our disparity in COPD, the impact of smoking has a very real effect there, and that's one of them. Is that people who experience depression and anxiety are more likely to experience tobacco use disorder, and down the road more likely to experience COPD. So this connection is insidious, and it's one that often takes decades to manifest. But the manifestations of these diseases, being just two of them, have very severe impacts on people's lives and the lives of their families and community members. So therefore, efforts to improve health outcomes for public housing residents should focus on physical and mental health conditions, as well as environmental and neighborhood factors. And if we could go to the next slide, please. Okay, so now we're going to transition, and I'm going to quickly get the link for the map here. And it will be in the chat.
Give me one moment. I may have to enable something in the chat.
Okay. Let me know.
Yep, it's enabled now.
Okay, and if everyone could go ahead and, is that visible, Vide?
Mm-hmm. Yeah, I can see it.
If everyone could go ahead and just open that link, I'm going to briefly go over sort of how the map works and the exercises that I'd like us to go through today. Here, so let me get back to my notes. So to help PHPC health centers understand the burden and the geographic distribution of SDOH related variables in their service area, we developed a series of interactive maps that include the location of the health centers, public housing development sites, and clinical and SDOH data. The map allows you to essentially collate these things and look at how they interact visually. In general, maps are helpful in and sort of connecting the dots and seeing how different layers of data interact in a way that's a lot, in my experience, a lot quicker to make connections than when you're just looking at a table. The maps were designed to help PHP's health centers in investigating and developing public health interventions that are most in need for their communities. And I hope being able to see these things layer on top of each other will make it clear sort of what is an issue and what isn't an issue in your area of service. Using the map, we can kind of zoom in for service areas and find the proximity of clinics, public housing developments, and hotspots for various social factors and so forth.
Sorry, Kevin, sorry to interrupt you. Let me go ahead and see if I can copy the link from my end. For some reason, they're not able to see it. Okay.
Oh, okay, yeah.
Just give me like 1 minute.
Mm-hmm. And you think we're good to go, Fide?
Yes, we are.
Okay, so everyone go ahead and pull that up, but I'm going to briefly share my screen and go over this particular one. Okay. Okay, so here, this map looks over socioeconomic health factors and public housing. And this, I am.
Sharing your screen?
Do you see it?
No, let me, okay, now we can see it.
Now you can see it? Okay, good. Okay, let me get myself centered here. So here we are, I'm gonna get us right over the DC area. Ooh. Here we go. Okay, so here we're over right over the DC area, and you can see the orange dots or the orange squares are individual public housing units, and the blue dots are individual PHPCs. And if you click to the layers over here on the far right, it allows you to put different layers of things you'd want to look at. Here I have violent crime. I'm going to go ahead and put up income inequality. You can zoom in and out in order to see sort of how these things manifest in different areas. Let's go back in again. And there are some telling patterns when we look at, say, for example, income inequality and where our units are. Violent crime. And here, let's take a look at firearm fatalities. So my question for you that I don't want you to answer yet is sort of what patterns are you seeing? I'm going to stop sharing. Go back to my slides. Sorry, and Fide, are we on slide 12 still?
Yes.
So let's go on to the slide 13, please. So, so mapping inequality, PHPCs, and residents of public housing. I'd like for you all to take 5 minutes to search your area of operation on the map. And you can do that by either putting in an address on the top left or zooming in specifically where you see it. And I'd like you to click income inequality and look at what you see in your area. And if we give 5 minutes for you to take a look, and then what I would like to hear is for some of you who are willing to give us some of your observations or some patterns that you're noticing specifically in your area of operation. And we will set a timer now. Well, I will say, if for those of you who are willing to share, I would like for you to sort of share your screen and sort of show us your area and show us what you're seeing, so we can engage in it together. Thank you. And Fide, in like 4 minutes, if you could take over, please. Thank you.
Sure. Hi, Jennifer. Thank you for providing that information. Do you mind sharing a little bit more? I guess once we are done, if you can just share, with us where you're joining us from and your title, or you can also provide it in the chat. Interesting.
Just realized I was muted. If any of you are in a rural population or a rural area that's where there isn't much there, I'd ask that you look at a close by metropolitan area that may impact or abut your area. For example, if you're in northern Mississippi, take a look at Memphis or something of the sort. All right, Pete, and that's time.
All right. So, Jennifer, would you like to participate verbally? Maybe provide some information, some insight on what you have found so far? Let me see if I can unmute you.
And if we could see your screen, that would be really cool, but no pressure.
Mm-hmm.
Hello.
Hi, Jennifer.
Hi. I don't think that it gives me a share the screen option. Let me see. No, it does not.
Okay, let me see if I can allow that. Yeah, maybe not.
And while Miss Fide is figuring that out, so I am from the state of Missouri, and if anybody's ever been to Missouri, we do have large metropolitan areas. The closest one to us would be Columbia, Missouri. It is about anywhere from a 30 to a 45-minute drive. And even in this large metropolitan area, the map is still showing that there is minimal public housing, as well as
Jennifer, you muted.
okay, can you hear me now?
Yes. Mhm.
Yes. So as you can see, this is one of the nearest metropolitan locations to Moberly. It is anywhere from like 30 to 45 minutes, and they're still showing, like a cluster of 5. If I were to go north to what I'm speaking about, which is Moberly,
Mhm.
still you're showing a cluster of 5. So the next I
Are
would
you,
say go ahead.
sorry, are you trying to share your screen?
It says that I am sharing it.
I
Oh,
actually have your area up right now.
okay. I'm not able to see it.
Okay, so let me stop sharing and then I will share again.
Mhm.
And hopefully it works for everybody.
Oops.
Can everybody see that?
Oh, it's coming. There we go. Perfect.
Yay. So of course here's Columbia. And then as you can see, the public housing is very sparse. I mean, you're looking at driving anywhere from 45 minutes to an hour away. Public transportation is very minimal. Like in, of course, the city of Columbia, they do have buses.
Mhm.
But here off into other rural areas, Uber and taxi companies are very sparse. So for major public housing to even be considered, you're looking at going to either side of the state, which is Kansas City or St. Louis.
Mm. Interesting, Jennifer, as I'm looking at your map, what I'm seeing is and there's some pretty high, and if I put on the layer for income inequality, um, some of the areas in your area, particularly Moberly and down in Columbia, we're seeing very high rates of income inequality.
Oh yes, absolutely.
Is that something you notice in your day to day?
Yes, very much so. Besides income inequality, it just affects so many social determinants of health. Community citizens, there's either no employment, or the employment that they are getting, the wages that they're making isn't enough to pay the median rent that is out right now. Homelessness is a huge issue. And of course, this is affecting mental health, it's affecting behavioral health, it's affecting everything. And it's pretty it's pretty scary in today's world, because people are picking, do I pay my rent, or am I going to eat for the next month?
Mm. So, I mean, isolation from resources is a key trend here that I'm seeing. Um, yeah. So, interesting. Okay, interesting comment from Andrea. Is very different from the map on Kevin's slide. There are no PHPCs in the area. where public housing buildings are clustered. And that's something I noticed looking at urban areas in general in the United States, where things are set up and where things are not. But one questions what the access to healthcare is for the folks living in the public housing units there. Is that something that you have insight into, Jennifer? Is there an issue, to your knowledge, with folks in public housing accessing healthcare in your area?
Um, I would say there there probably is a percentage. Usually people who are in public housing in my area, we're trying to address that. Of course, they are signed up for Medicaid because Missouri was one of the states who got Medicaid expansion.
Mhm.
So if they, of course, are signed up for Medicaid, Medicaid covers their transportation to and from their housing to their doctor's appointments or to their doctor, even if it is from like Moberly to Columbia or from Moberly to St. Louis.
I see. Interesting. Well, thank you very much for sharing, Jennifer. Does anyone have a urban area that they've been looking at that they would like to share? Okay, let's head on to the next map then. So we're on slide 14. So next one, please. Yeah, there we go. So mapping adult smoking risks. So adult smoking risk and tobacco use disorder give an interesting insight into mental health conditions, because the two main categories of things are so well connected and kind of experience a feedback loop. Folks that experience anxiety and depression are much more likely to also experience tobacco use disorder. And tobacco use disorder is it makes it more difficult to quit smoking, and because of that, we see a feedback loop of making it very easy for folks that have these conditions to get addicted and very difficult for them to leave the addiction. So this is the mapping and smoking risk. And I look here at the Washington, DC and Baltimore area and sort of see the clustering of where the public housing is, where PHPCs are, and where smoking risk is. And it gives a very clear picture of folks in public housing in this area being exposed to more smoke and being more likely to smoke. So next slide, please. I'm going to give a link for the smoking map. Oh, wait, I'm just going to host and panelists, excuse me.
Yeah, make sure it says to everyone.
There is the link. It's available to everyone. What I'd ask is if you please take 5 minutes to take a look at and let's call it 3 minutes to take a look at your area, and then we'll ask someone to share. And so that's starting now.
Okay, so do we have a volunteer? Somebody that would like to participate? Okay, we have a volunteer, Laura. Okay, give me 1 moment.
Hey, can you hear me okay?
Yes.
All right, let me just share my screen really quick.
Oh, give me 1 moment. I need to make you a panelist
Oh, okay.
so that you can share your screen. So you're gonna be moved to another window, okay?
All righty.
So make sure that you accept that. All right. Let me stop sharing and now you can share. Are you able to share your screen, Laura? And you're muted. Also. Okay. There you go.
There we go. Can you guys,
Mhm.
oops, not that one. Sorry, guys, hold on. Okay, can you see that okay?
Yes.
All right. And did you hear my little spiel about Fairfax?
No.
No, okay. All right. Well, yeah, you guys were kind of looking at the screen a little bit earlier, but I'm from Fairfax County, so it looks like we have really low rates of adult smoking, and yet we have a ton of public housing. But just by looking at the map and kind of based on our own analyses, a lot of this public housing is in lower income areas. So we have like the Route 1 corridor down here by Groveton and around this area called Bailey's Crossroads. And these areas tend to have metrics that are pretty high for like rates of neoplasms, premature death, poverty, things like that. So it's no surprise that we have a lot of public housing in these areas. It's probably strategic, but it is interesting that we don't have a lot of smoking.
I'm interested to see if you click on the layers and put drug overdose. Are you noticing like similar? And you may need to shut the adult smoking off.
Fairfax City, this little blob right here looks like it's pretty high. We've got a little cluster here, public housing.
And what's your experience of a drug overdose being its level of severity within your community? Does that correlate with what your knowledge is?
For Fairfax City, this is actually where we have a university, so that could make sense. Generally, if you pick apart Fairfax by census tract or zip code, you do also tend to see drug overdoses by these corridors, like I mentioned earlier, kind of up here near Reston, the Chantilly area. So those are, I guess they're kind of getting blended in with Fairfax County as a whole. So it's not showing the density as much.
Yeah, these measures are at the county level, so it's not possible to see more detail there. But thank you very much, Laurel.
Yeah, of course.
And Laurel, where are you joining us from? What?
Fairfax County.
Okay, the health department?
Mhm.
Okay, thank you.
Okay, Theda, if you could bring me back to slide 15 when you get a moment.
Mhm. Okay.
Okay. So anyhow, working next to drug overdose deaths. We won't go through, we did this a little bit with Laurel's example, but this is one a layer I recommend taking a look at too. So here drug overdose deaths are shown with the location of PHPCs and the housing units in the DC area, which is my area. And some interesting patterns that show you where these things are and where they overlap. So something I recommend putting your area code in and seeing how your metropolitan area looks. Down to section 2 impact on page 8, sorry, slide 18, please. Okay. Here we're understanding the connection between social behavioral health, the SDOH, and geography. Next slide, please. So here are some results from the mapping analysis that we performed, sort of looking at some of the SDOH and how it compares for counties with a PHPC and the US average. So educational attainment, as we reviewed earlier, is intricately linked to housing status. And these factors have an impact on a variety of health measures, including those that related to one's physical and mental health. Our analysis found that the counties with PHPC health centers had lower high school graduation rates and a percentage of individuals completing high school compared to the US county performers. So, and that's a fairly wide difference, 77% versus 94%. If you can consider the proportion of people that takes up nearly 20% and how much that can impact a community over decades of experiencing that, it's significant. Next slide, please. So income inequality is tied to a number of poor health outcomes in areas where it's manifest. As you all may know from your work in your own service areas, these impacts have been shown to impact mental and physical health through higher rates of depression, anxiety, SI, and substance misuse disorders. Counties with PHP health centers also experienced larger gaps in or inequalities in income compared to top US county performers. They had higher unemployment rates and a higher proportion of children living in poverty. And just to look at these, some of the numbers that pop out a little more is the children in poverty, 19 versus 10%. That's significant. Completed high school, 4% versus 2.6%, and income ratio, 5 versus 3.7. Next, please. So mental health, and using frequent mental distress as the main metric here, small differences in the level of mental distress in communities can have severe implications on the social and economic health of the communities. This impacts employment, family structure, as well as the frequency and quality of interactions, which are essentially the underlying fabric of a community. So small differences make a big difference on this metric. PHPC health centers are located in communities that experience a greater level of mental distress and mentally unhealthy days. We found that 15% of individuals living in counties with PHPC health centers reported frequent mental distress compared to only 12% of the population in other US counties. They also had an average of 5 mentally unhealthy days compared to 3.8 for US counties. Next. Tobacco and alcohol use disorders are mental behavioral health conditions. They are also often connected to other mental behavioral health conditions such as anxiety and depression. These often function in a feedback loop. For example, major depression, MDD, leads to higher likelihood of tobacco use disorder. In turn, tobacco use disorder can increase the severity and frequency of depressive symptoms, which can lead to more frequent smoking. So these things are intricately connected. PHPC health centers are in counties with slightly higher smoking and excessive drinking rates compared to the US counties. Approximately 18% of the adults living in counties with PHPC health centers are current smokers, and 17% report binge drinking. I will say that smoking and binge drinking in general is something that we see across the country as being a major issue, but this disparity is important nonetheless. Next, please. Substance-related mortality. Despite only slight difference between rates of smoking and drinking in counties with PHPC health centers compared to US counties, we found larger differences in substance-related mortality. Approximately 24% of driving deaths in PHPC health center counties were alcohol-related compared to 11% in top US counties. That's a big difference. While drug overdose mortality in PHPC health centers with 21% compared to 11% in the top US counties. So this metric is more telling than the others in that we're noticing almost a 100% difference in counties with PHPC health centers versus those that do not. Section 3, research and best practices. Next slide, please. So here I'd like to, and this document will have links available if you'd like to take a look at the research yourself. I would recommend doing so. These are some great papers that I came across in my literature review that are worth your time. So the link between housing, neighborhood, and mental health. In this paper, the relationship between poor housing and mental health is reviewed, and some of the conclusions are telling. One, poor housing conditions are associated with more depressive symptomatology and hostility in individuals living in those areas. Perceived overcrowding increases the risk of hostility, and neighborhood social cohesion reduces the risk of depression and hostility. So this supports the thesis that improving housing has a direct impact on mental distress and can improve neighborhood social cohesion in real ways. Next, please. Housing and neighborhood, physical quality, children's mental health and motivation. This paper, again, great read, would recommend picking it up. But to go over some of the main takeaways and the implication it has for our practice, this paper investigates the impact of housing and neighborhood on children's mental health and motivation. Analyses focused on two critical components of child development, one, psychological health, and two, feelings of helplessness. The analysis was a growth curve analysis with a multi-level modeling system that revealed that lower quality housing was associated with poor psychological health. And that's internalizing and externalizing symptoms, as well as marginally more helplessness or behavioral and difficulties with behavioral tasks. And that's for children over 15 years and for those age 9 to 14 years. The important thing here is this paper supports the thesis that housing is intricately connected to mental health, that the relationship is very strong statistically, and that it disproportionately impacts children. What this tells us for our practice is the need for prioritizing children and family and housing interventions and the importance of housing first interventions. Next slide, please. Could you go back one? Okay, the impact of interventions for youth experiencing homelessness on housing, mental health, substance use, and family cohesion. This is a systemic review and looks over a variety of papers that have been published on individual cases. So youth often experience unique pathways into homelessness, such as family conflict, child abuse, and neglect. This takes a look at the specific interventions that could help. In particular, groups were given cognitive behavioral therapy and housing first intervention And unsurprisingly, those that received those interventions experienced much lower rates of a variety of comorbidities, including depression and anxiety and suicidal ideation. What this tells us is, one, the importance of housing first intervention, but that when housing first intervention is performed in concert with cognitive behavioral therapy, that this has a logarithmic relationship, as in it's not just cumulative, it makes things much, much better. And the takeaway here is housing first interventions have been shown to work. Giving individuals housing is an effective way of reducing the need for emergency room care, for improving health outcomes and so forth. But when that's combined with cognitive behavioral therapy, we see proportionately greater increases in that. Next, please. So this is a paper that I utilized in a recent review for a paper I published on emergency department utilization in unhoused populations. I will say this is published in 2014, before the term unhoused was being used, and when this population was still described as homeless. But this intervention essentially followed unhoused individuals that were regular users of ED services and applied a housing first intervention. Findings showed significantly lower ED utilization by individuals who received the intervention. Emergency room utilization is a good metric of poor mental health care in an area, as unhoused populations are more likely to experience these conditions, and these conditions are very likely to need emergency care. When I was in training at GW, there was, in my emergency medicine rotation in medical school, there was a gentleman that would come in fairly frequently. He was an unhoused individual and had severe alcohol use disorder, and would come into the ER, I'd say 2 to 3 times a week. Throughout the year, his medical bills came to about $2.1 million. So in addition to having a very real human impact on an individual like this, who's experiencing consistent symptomatology, this also has an effect on the financial health of institutions as well. In general, housing first interventions have been shown to improve outcomes for both the individuals involved, that being the unhoused or moderate or marginally housed populations, but also for the institutions involved, the emergency rooms, hospitals, and clinics. And we're up to 5 minutes left. I guess we'll open things to questions, concerns, or points of interest. And I thank you all for your time and your effort. I encourage you to use the tool for fun, or to help you discover what kind of programs might be more helpful in your area. And encourage you to read the papers and engage with the material academically. And if there are none, Fide, we can go ahead and wrap up.
Yeah, we don't have any questions.
Thank you all for your time. Have a lovely week. And if it's sunny there like it is here, hope you enjoy the weather.
Mm-hmm. Thank you. You're welcome, everyone. And please just remember to complete our post-evaluation survey. And this is our contact information if you have any follow-up questions. All right, have a nice day.